Hey guys, I'm Carol Flowers. I'm a nurse practitioner student at Auburn University, and I'm going to talk to you today about prescribing glucocorticoids or the corticosteroids. Okay, there's multiple drugs in this class, including your short-acting, intermediate, long-acting, topical, inhalation, and nasal. But what these are used for are to systemically treat and replace for adrenal insufficiency, but larger doses can also be used for anti-inflammatory and immunosuppressive properties. Topicals can be used for inflammatory and allergic conditions. The inhalation can be used for management of reversible airway disease and also intranasally for allergies. But the way these work are they depress proliferation of the T lymphocytes, they decrease your natural killer cell activity and reverse the macrophage activity and inhibit the immune and inflammatory system. They increase your circulatory erythrocytes. They can increase your appetite, promote fat deposits in your face and cervical areas, and they can promote lipolysis in the extremities and have an increase in uric acid excretion. This is a chart just comparing the pharmacodynamics and potency of the different drugs. These drugs are well absorbed in the GI tract. They're metabolized by the liver. They're excreted in the kidneys. They're contraindicated in patients with active, untreated infections, and you want to use caution in patients with hypertension and cardiovascular disease because it elevates the high blood pressure and it can cause them to retain salt and water, and it also increases their excretion of potassium. You also want to use in precaution in postmenopausal women for risk of osteoporosis. Diabetics can have problems with glycemic control, and they can cause some GI bleeding, muscle atrophy, delirium, agitation, insomnia, mood swings, adrenal suppression if stopped abruptly. So you want to monitor for all these. It can also affect other drugs like diuretics because of the increased loss of potassium. It can cause increased risk of digoxin toxicity, and it can affect your requirements for insulin and hypoglycemic agents. So you want to just be cautious with that. Some conditions that this drug class can treat are your adrenal insufficiency, your inflammatory properties, your immune suppression, rheumatoid arthritis. When drug selections are being made, you want to look at like the short-acting agents are less likely to produce the hypothalamic pituitary adrenal axis suppression, and the longer actings are preferred if the effects of high doses are to be sustained. You want to monitor for weight, electrolyte, glucose, CBC. In long-term or high-dose therapy, you want to monitor for GI bleeding and lipid panels, and also have routine eye exams done. You want to teach your patients that administration is to be taken exactly as prescribed early in the morning. You can explain the alternate day or the taper dosing if you choose to do that route. Drugs should never be abruptly stopped. You want to teach them about the immune suppression, the GI bleeding, and the healing, the non-healing source, and the changes in their body. Lifestyle, you want to tell them to wear a medical alert bracelet and have a diet high in potassium and calcium and low in sodium and carbohydrates. Some of the takeaways is you want to best match the natural's body rhythm and to be taken in the morning. The initial dose is very specific to what you're trying to obtain with your prescription. After you have achieved your acceptable response, you want to make sure you're on the lowest dosage to maintain that response. And you also want to just make sure that when tapering off that if they are not tolerating the drug that you're tapering it off. You can also do alternate day and it gets the same daily dosage as being on it every single day. So these are some of the takeaways of prescribing glucocorticoids to your patients. Thank you.